Welcome. I'm Dr. Vinay Prasad. I'm a hematologist-oncologist, and I'm Associate Professor of Medicine at the University of California, San Francisco. In my professional life, I see patients, I teach trainees, and I do research in healthcare policy. This is Plenary Session. Plenary Session is a podcast at the intersection of medicine, oncology, and health policy, and you're listening to Season 3. On this week's episode. On today's Plenary Session, I have an interview with Alasdair Munro. He's a pediatric registrar in the United Kingdom, and he is an expert in tracking COVID's impact on children from a health perspective. You won't want to miss this discussion. But first, a plug. On Plenary Session, we've heard listener feedback, and we're going to try something new. We're going to take our long episodes, and we're going to put them out piecemeal, little bit, just as you've asked. And then we will see what happens and how people listen. So, the experiment's on. If you like this podcast and want more content, follow me on Twitter at vprasadmdmph. Check out the YouTube channel, Vinay Prasad, MD-MPH. Patreon backers will get access to the slides for lectures I give on Plenary Session. Want to hear from us? Email us your question at plenarysessionpodcast@gmail.com. It's the holiday season here at Plenary Session, and that means it's time for our semi-annual pledge drive. That's right, Plenary Session is supported by Patreon backers. You got to go to patreon.com, find Plenary Session, and if you are a plenard, if you're a fan of this show, you need to donate to this show to keep it going. Plenary Session has no other support. We don't do advertisements. We keep it pure, and so we are supported by small backers. So if you enjoy this podcast, you should support the show. If you don't enjoy this podcast, you shouldn't support the show. I wouldn't recommend it, only if you enjoy the podcast. So, on that positive note, we only do this twice a year, bug you. And it is that season. We're going to shift to today's episode. I'm back in Plenary Session HQ, joined once again by Alasdair Munro. Alasdair Munro is a pediatric registrar in the United Kingdom, and he is an evidence-based medicine expert and somebody who is taking a close look in multiple systematic reviews of the literature around COVID-19 in school-age children. Alasdair is also a guest of this podcast before. Alasdair, it's a pleasure to have you back.
It's a real pleasure to be back. Thanks, Vinay.
I wanted to start by a topic that, and of course I didn't tell you what we're going to be talking about, so I like to keep my guests guessing, but I wanted to start with a topic that I think is something you've reflected on. Do you feel that in this increasingly online world of SARS-CoV-2 discussion, that there are camps that are extremist? And by that I mean, in one extreme, there's a fearmongering camp. Everything is the worst that could ever be. And in the other extreme, there's a camp that literally thinks nothing is going on. I mean, I don't know what that camp is, a completely delusional camp. And one struggles online to try to guide the ship somewhere between absolute denial and absolute everything about this virus is the worst virus on earth. Do you feel this pressure, and how do you think about this?
Yeah, I definitely do think that that's the case. And it's been a real struggle, actually, in terms of trying to communicate a lot of the science around this. I'd love to blame the politics for it. And I do think that's certainly played a role, particularly for you guys in the US, because it feels like a lot of what happened was really, the administration, which is, soon to be no more, but took, quite a unique view on the pandemic in the early stages. Yeah. I think was viewed really as just being pretty dismissive. And then, of course, there were, as you say, more fringe elements, that range from it's 5G, it's not real, there isn't a virus, to, yeah, there's a virus, but actually really no one's dying. It's just, we're just counting up deaths that would have happened anyway. And, but all sort of down that end of the spectrum. And the problem is that the response to that from, the infectious disease and epidemiology community in particular was hardcore, we've got to show everyone how bad this is. And, it's not hard to do in many ways because it's killed 1 million people. And that, by and large, should be by itself ample evidence, really, for what's going on. It's not a hard case to make. But I think what you're talking about is where really, in an effort to sort of, people see those numbers, and then I think when people realise that, the public wasn't perhaps as terrified or I don't know, falling into line or whatever as much as people would have liked, that more was needed, more fear, I don't know, was needed. And there was just this sort of strange focus on, elements of this infection that I guess we really see for a lot of other infections, rare stuff, but once you infect millions and millions of people,
rare stuff is common. Yeah, rare stuff is common.
It's relatively common, yeah. But the absolute risk and relative risk get a bit muddled up, and also the risk of something, although the risk of you getting infected was high, the risk, per infection of once you're infected, the risk of having some of these rare events was not necessarily more common than for a lot of other infections, but a lot of it started getting blown out of proportion. But anyway, I mean, this was particularly acute online, I guess, on Twitter, as it always is. It's strange, actually, when you spend a while on Twitter, doom scrolling and seeing all this stuff. It's sometimes a bit weird to go back into real life and go, I can't believe, people seem to think that, we're all going to drop dead of myocarditis from COVID.
Yeah.
And people at work are like, what?
I feel the same way.
What are you talking about? I've never heard of that.
They're like, what are you talking about?
And these are doctors, who are treating people with the COVID. Who are like, I have never heard of anything you're talking about. What is this argument?
And then they're like, you're like, oh, you hear about T2 weighted cardiac MR? What are you talking about? T2 weighted? The patient feels fine. Get the hell out of here. What are you doing? I find the same exact feeling, and I feel like, as much as I try to not be affected by these polar extremes, particularly online, I don't know, it must creep into my own thoughts about it. Just for one instance, everything is through this lens. So, somebody tweets that, of course, there's no excess death, which is crazy. Then somebody tweets that there is excess death, which, of course, there is. There is an excess death. But then I want to point out that, look, much of that excess death is COVID. Some of that excess death might be hospitals and people's behavioral change in different ways in response to COVID. And it's going to take a long time to sort that out. And that's, we shouldn't forget, there's an empirical question here that someday we want some good researchers to go in and kind of parse this out a little bit and get some sense about, were there things that were missteps and were there missed opportunities? I mean, that would be a useful learning exercise. But then I feel like you try to come in and say that in the middle of these warring parties, and it is quite difficult.
Yeah, and it's a dead zone. It's a dead zone as well because on Twitter no one is interested.
No one is interested.
No one is interested because on Twitter masks are either the tool to end the pandemic, or masks don't do anything at all, and they may even kill you. And actually, some of those excess deaths are due to masks. We're killing people with the masks. Their CO2's going up, and they're just dropping dead in the street from masks. And it's the same with everything. And if you tweet one of, and if you take one of those two things, you are, your retweets and your likes are going through the roof, and you're getting followers, and you're thinking, oh, people like that. Oh, this is good. This is good stuff. And it is, and you can sort of see people taking these, there's a few famous examples, I think, of particular, Twitterati whose emojis and all caps and stuff.
Breaking news. We're going to get into that.
And again, and it cuts both ways. If you're saying, if you're saying, that it's all completely made up, people love it, and the way it polarizes the discussion is so unhelpful. It's really difficult to inject any nuance, because the thing is that if you do try and come into a conversation where like you said, and instill a bit of balance, or to suggest that there's some other considerations, then people just go, oh, so you don't believe it's real?
I know.
Or the other, you go, oh, so you think that we should just be locked down forever, and that and you're like, well, no, that's not what I said, and it happens all the time, and you just end up arguing, or people end up arguing with you about things you don't believe and haven't said, and it's not even just what we might think of as the loony bin or whatever, but it's academics.
Yeah, no, I've seen. Yeah, they argue with some things you haven't said, because everyone is thinking 4 steps. Like, if he said this, somebody might think it means this, and therefore they would have the wrong impression, and therefore I need to go in really hard and go up and correct this.
And I heard, I listened to Wes on your podcast as well, who was saying that that's crept into a lot of the, a lot of major scientists or academics. They're thinking about what can I research in case it's taken the wrong way. He gave the example of seasonality and that kind of thing. And I think the same thing go out with herd immunity.
You can't even say that.
No, you can't. And there's loads of stuff you just can't, there's just things you can't say,
I felt I was treading on thin ice when, I'm reading all these increasing calls to first they're like, people who don't want to get vaccinated should be encouraged to get vaccinated. People who don't want to get vaccinated should be mandatory vaccination, or you can't participate in society. People who don't want to get vaccinated, we should shoot them all in the head. I mean, they're really getting riled up. They keeps escalating. What are we going to do with these people who don't want to be vaccinated? I was like, look, let's just take it one step at a time. One, there's at least 60% of people who really are keen on getting vaccinated, and there are not enough vaccines. So let's just do that first 60 first. And then, just like the iPhone, people are going to see us getting vaccinated. We're not all going bonkers. They're going to want to get another 10, 20%. Easy. They're all going to jump on. They're going to see how much fun it is, how much a good time we're having getting vaccinated and not dying of SARS-CoV-2. They're going to want it. Okay, so now we get up to 80%. The other fraction may have already had COVID, in a large chunk of that, especially in this country where it's running rampant. And
particularly the people who perhaps don't believe that they need the vaccine.
Exactly. I mean, those two, it's an overlapping Venn diagram. And then we may be at something called, I don't know if we should say it, but there might be some herd immunity. Yeah, don't say it. There might be some herd immunity going on. And then you don't need to shoot them. You don't need to punish them, because it doesn't matter. You can let it go. Let it slide. It's just like, early in the pandemic, somebody's like, somebody walked into a Home Depot without a mask, and they're like, why didn't they call the police? I was like, what is the goal of the interaction? The cop's going to go up there. So I don't want to wear a mask. And then he's going to be spraying the cop in the face. I mean, it's just going to promote the virus transmission. You're not curbing it.
Yeah, and I think that's a really, really important point, actually, that I've tried to suggest a few times on Twitter to people who I'm sure are well-meaning, who, have taken this quite, I don't want to say, fear-mongering is a really extreme way of saying it, and that's not necessarily what I mean.
Exactly, the label fits.
There are some people who are absolutely doing that, but even people who, just tend to focus a bit more on the negative or on the scare stories or all that sort of stuff. I'm sure a lot of it is well-meaning, and that the purpose of it, even if they're not aware of it, is to try and convince people or try and get people going to think, this is bad. We need to be doing more about it. But the fact is, it has the opposite effect. It's so counterproductive, because the people who are dismissive, if they smell you over egging something, if they smell the exaggeration, then they go, I knew it. I knew it was all being hyped up. You saying all this,
and it stinks of it. I mean, even I can smell it a mile away. That is, you're spinning it a little hard.
Yeah,
I'll give
exactly.
you.
And those people are either not listening to the New York Times or whoever these academics are, because they don't run in those circles, they're not paying attention, or if they hear it, it just puts them off because it just smells of exaggeration. It just confirms their beliefs that people are overhyping it. But the people who are listening are the people who are already convinced and are pretty terrified. And actually then they're hearing, oh my gosh, even if I don't get symptoms, I could die if I go for a run because I might have organ damage.
And that is,
it could be my brain.
God, and that is really one that kills me. Oh, but I got to tell you one thing real quick. So I recently tweeted, I was talking to a colleague, and this colleague lives in Florida. And, this country is, we're polarized. And California and Florida, they're both warm, but they're as different as they come. And in California, cases are on the rise, unfortunately, very unfortunately. And they've issued some new orders. Of course, outdoor dining is banned. I'm not exactly certain to what extent outdoor dining was contributing, but nevertheless, it's off the table. And then the playgrounds, they taped up those playgrounds. They know what's going on at those playgrounds. And you know what's going on at those playgrounds? Rampant SARS-CoV-2 transmission. You want me to prove it? It's going to be a little tricky to do that, but we roped those off. Meanwhile, I talked to my colleague in Florida. My colleague was saying there's people having dining indoors in a restaurant. And I'm like, what are you talking about? Indoor dining in a restaurant? And he's like, oh, don't worry. When you go to the restroom, you got to wear your mask when you walk around. I'm like, that's not going to do it. That's not going to stop it. What are you talking about? And so then I tweet, I was like, in Florida, they're having indoor dining in restaurants. And here in California, we're one step away from a mask mandate in your own shower. I was like, this is, that's my tweet, which I thought was funny. I didn't hear you laugh, but I see you.
I think it's funny.
Okay.
I'm laughing on the inside.
I'm laughing on the inside. That's the hallmark of a good comedian. You get a little smirk out of your audience. Okay. Anyway, so I thought it was funny, and then I go look a few hours later, and it's like obviously a million comments. How dare you do this, you son of a bitch? And I was like, what are you talking? People all hate me for saying, and I'm like, it was a joke. My God, it's a joke. And then they're like, oh, so you want to live in Florida? Why don't you go to Florida? I'm like, no, I obviously don't want to live in a place that has circulating SARS-CoV-2 in an indoor dining hall. No, of course not. They're both bad policy. That's what people don't see. You can have extremes in both directions. There is something in the middle. It's called common sense. But anyway, I just tell this story because I was like, I also want to talk about, I think I feel obliged to mention the elephant in the room, which is that, people are at home, and as much as everyone thinks that they are doing okay, I think a lot of people are suffering. We're a social animal, and when you're at home and you're suffering, and the thing that's causing your suffering is to some degree outside of human control, it's a lot easier to find the villain of the day and, jump in their mentions or vice versa. The other thing I wanted to say real quick about what you were pointing out is I think the feedback system of Twitter is the core problem. Like, it rewards you. You get a dopamine hit every time you go push yourself more in one direction or the other. And it just encourages people to go more in whatever direction they started it. So they could either go more in the sky is falling, or more in the direction of it's a nothing burger. Both are wrong. Oh, and then the last thing I want to, actually, I'll save it for the next thing. You're going to say something, and then I'll bring up my next topic.
Yeah, I guess the best example I've got for this really is the thing I talk about more than anything else, which is schools and is COVID in children. Yeah. And I've just, the number of times you'll send out a tweet and people will be like, oh, but here was an example of when a child did catch COVID.
Yeah.
And you're like, well, yeah, I'm not saying children, what's difficult is that the message is subtle, which is that children do get infected. Of course they do. Children do transmit it. And
some have died. Very rarely, but some have died.
Yeah, exactly. Yeah. And it's not, and the transmission is not negligible. Fortunately, no death of a child is negligible, but the rates at which this disease is fatal in children is by, normal infection standards is normal. It's the equivalent to other respiratory viruses for which we don't, we're not too concerned. But, if you try and talk about the transmission and say, oh, look, it's not as bad as adults. And that's good because this is really different to other respiratory virus, pandemics and the ones that we normally have to deal with. And then people are like, so that you think they don't get it, or they don't spread it, or spread isn't happening in schools. So we don't need any infection prevention measures in schools. And, you just say, well, no, that's not, I haven't said any of those things. In fact, I've been copying some flack recently from people saying, so you don't think we need infection prevention in schools? I've literally published a paper with recommendations for what infection prevention measures you should have in schools. Uh-huh. Now, there may be some disagreement. A lot of people feel like children should all be in masks when they're sat at classrooms at their desks. That's not the current policy in the UK. I understand why, because they felt it's, if kids are sat alone at their desk facing forward doing their work, having a mask on is probably not doing much when they're not socializing or whatever. So, I think that's fine. Some people really feel very strongly that they should have masks on all the time. If that was introduced, I, wouldn't be bothered by that. But, the fact that I'm not shouting from the rooftops, masks in classrooms suggests that I don't think.
But don't you remember all those cluster randomized trials of children wearing masks in classrooms that we did?
Well, I tried. This is the point. So I tried to engage with someone about this on Twitter, and I said, "Well, look, it's just a difference of opinion."
Exactly. There's no fucking opinion. There's no fucking data. There's no data. There's no data. Yeah,
that's right. Yeah, I said, you feel really strongly that they should wear them. I'm pretty indifferent. If we said they had to wear them, that would be fine. And the reply was, it's not a matter of opinion. We have the aerosol science.
The aerosol science.
And the thing is, you just can't. Twitter, unfortunately, can't. It's too much effort sometimes to spend.
And let me unpack. I just want to unpack.
That level of evidence doesn't explain children at their desks in classrooms wearing masks as a contributing factor. Anyway.
And I want to unpack that a little bit. I mean, I think why are we critical of quote unquote the aerosol evidence? And the reason is it would be the same arrogance as somebody walking up to me, a cancer doctor, or you, a pulmonologist, and saying, I have a new drug that treats whatever condition you treat, idiopathic pulmonary fibrosis or, cancer. And I say, great, show me the evidence this new drug helps. And then they're like, well, I did this pipetting experiment and it looks like it hits the target. And I'm like, okay, so what happened when you did the human studies and you asked what happens when you actually give it to people? Oh, I didn't do that. I was like, get out of here. Get out of here. That's not data. I was like, we know that stuff's going to fail. And so similarly, although it is compelling and the aerosol hypothesis is, interesting. I mean, I'm interested, just like I'm interested in little pipetting. It's not relevant to the actual, in this case, it's even more complex. It's a social behavioral compliance intervention. And that data, unfortunately, has almost no explicative ability about the actual question you're facing, the policy decision. And so it really is quite reductionist. And I think there's a class of people who haven't played in the medicine public health ballgame before, and they're coming in from whatever ballgame they've been in, where you can live your life as a reductionist, and maybe I don't even know if you're right or wrong, because I don't know what sort of external tools they use to judge their success or failure, but they're playing their reductionist ballgame, and then they come into my game, and they think their reductionism works, and I want to tell them, you need to sit down. I got to explain to you, reductionism in medicine, that ain't going to get you far, my friend. That ain't going to get you past second year medical school. You got a lot to learn about empiricism and actual relevant data. And that's the hard conversation to have on Twitter because people don't know that, I think.
Yeah. And I get the feeling that, it's a bit like washing your hands. Like, we haven't generated the evidence for washing your hands. And so then there's like a cost benefit scenario in, this high risk situation because we're in a pandemic. But the fact is, even for washing your hands, so for example, when they reopened schools for like the under 10s in Denmark, they had to wash their hands every 90 minutes, right? Mm-hmm. And they had to stop because their hands were raw because they were bleeding, because that's what happened. We all know, the healthcare workers, we're washing our hands all the time with all of this stuff.
Oh yeah.
Eventually it does get sore. And so there was does washing your hands more reduce infections? Yes. But even for hand washing, there comes a point where if you're washing your hands too much, actually the harms of that infection prevention measure outweigh, the meager benefits of, washing them every hour and a half as opposed to every 3 to 4 hours or whatever. And so the same applies for mask wearing and will apply for anything. But if there's ways that it inhibits or that it causes problems, if you don't know the actual effect size or, you're working on the assumption that it's going to be operating under not optimum conditions, particularly when you've got kids wearing them in classrooms. If it's a low risk environment, there's going to be times where it is possible, or at least in someone's opinion, the marginal benefits would be outweighed by the risks, and people should feel free to have a disagreement and to talk about it without being lambasted. But as you said before, masks have become somewhat a bit of if kids taken on a life of their own, really.
If kids didn't wear masks, how would I know who's going to vote Democrat someday? No. Okay, next question. I was reading this. I don't know. I shouldn't have even looked. I should have known better when I looked. But I was reading a guidance from the American Academy of Pediatrics, who, you've already slumped over.
I know exactly what you're going to ask me about.
Well, I love the AAP because they really like sticking their nose in things where they have lousy data. A few years ago, we did some of their work on screen time, and I looked through the data, and I'm like, oh God, they're like, no child should ever look at the screen unless it's Sesame Street, in which case they can watch it because that's a good program. I'm like, get out of here! What are you talking about? This data is garbage. And then I looked through the data, and it was very bad. And people should go back and listen to a podcast I did. It's like season 2 on this episode where we talked about the screen time papers. Okay. So anyway, now they got a new paper out, and it's like, what happens for a kid who's recovered from COVID? And they put them in 3 buckets. So the bucket 1, the asymptomatic child who recovered from COVID. To be honest, many of them may not have been labeled as recovered from COVID because they may have had the sniffles one day and, the parents ignored them and they got better and who knows what they had. Okay, that's one. Or actually asymptomatic. I don't even know. Okay, that's even worse than that. They don't even have the sniffles. Then there's mildly symptomatic. And then there's people who had fevers for more than 4 days, and they've recovered. And then the guidance is for the asymptomatic and the mildly symptomatic, before they can exercise, you got to stop yourself, go to the pediatrician, and the pediatrician has got to ask them 14 questions, the 14-point screening. And the screening is like, did anyone in your family die younger than the age of 50? Do you have any chest pain when you exert yourself? Which is a catch-22 because you've prevented them from exerting themselves until they can get clearance. So how would they know if they have chest pain when they exert themselves? Anyway, and if they did have chest pain when they exert themselves, I imagine they would volunteer that information. Or look like they're not doing so hot. But anyway, you got to do this questionnaire if it's mild or asymptomatic. If it's fever for 4 days, they have to be seen by a pediatric cardiologist before they can return to exercise. And then when they return to exercise, they cite this British Journal of Sports Medicine paper, and it has this like huge color-coded chart. You know how much I love color-coded charts this year. And it was just entirely fabricated. And it was like, for 10 days, do nothing. And then 2 days, you can go up to 70% target heart rate. And then 2 more days, go to 80%. But don't make it 3 days, because then you got to go to 85%. And it had this huge thing. And it was like, only by day 17 can you exercise. And I'm like, are these people out of their mind? The kid recovers from COVID. Mommy, Daddy, I want to go play. I want to go on the playground. And then the parent's like, no, we have to wait for that pediatric cardiologist appointment. And when is the appointment? It's actually in April of next year, because they have no availability in this country. They have no availability. And April of next year. And until April, Tommy, you're going to sit there on the couch and not exercise. And then you see him like running off to his like bedroom. I'm imagining some kid. And then he say, no, slow down, your heart. I mean, I just like, I guess the reason I laugh so much is it's so absurd. But it's really serious. It's a torture for the parents. And what data do they have? I mean, they just made up the whole thing. Okay, thoughts?
Yeah, so I mean, this I suppose this is on 2 things really. So one is that I'm not terribly keen on issuing guidelines where there is no evidence, because essentially if what you're suggesting is wrong, then all you're doing is making sure that everyone does the wrong thing, and so you're potentially increasing harms. Variation in practice is not bad if the alternative is everyone doing the same bad thing. So I'm already a little bit aghast about that.
Yes, that's a well put, yes.
And the next thing is, I guess, so the next issue is that this all came out of the hoo-ha about myocarditis in athletes, and, a few papers which were, I guess, turned out to be somewhat problematic in terms of their methodology, and some of the data it turned out was not right, which is
You're so polite.
Which was a bit of a mystery. Yeah. It's still a bit of a mystery, and just an extraordinary amount of excitement about the possibility that young people with COVID might have myocarditis, and this goes back to what we touched on earlier, these MRI findings of totally uncertain significance, or finding of abnormalities in imaging with completely normal blood tests, markers of inflammation, normal troponins and normal CRPs afterwards, and the fact that actually, if you do these types of investigations at this scale for a lot of other respiratory viruses, you find the same sort of stuff. Like, we just don't always look for it, and we're just not always quite so focused on it. So I guess
But
these
people
guidelines came out really
people were
quickly.
so excited on Twitter to see it. I'm like, what? I kind of getting creeped out by how they were almost salivating over they're like grateful to have these findings. I was like, you got to ease up. This is not real. This is not.
Well, I think this tied into something that this sort of undercurrent that came out from one sort of side of Twitter, which was that when it became more clear that this disease was extremely lethal for the elderly, but for the most part was, usually a pretty benign acute illness for young people, that a lot of young people, I think, there was a feeling that a lot of young people, therefore, were not quite so concerned about going to bars, going to parties, indoor dining or whatever.
Right.
And that the message, you've got to stay home to protect other people was not enough. I think that's how some people felt. And I think that therefore the response to that was to try and convince young people, this is really, really bad for you too. You should be really scared to get this infection.
Right. And,
part of that was talking about these asymptomatic people and the athletes getting myocarditis. And, there was a lot of focus on long COVID as well, which affects
that's my next question.
People. I felt like, and there was quite a big push for this. And I felt like maybe some of the focus was, as I said, to try and convince younger people that it wasn't just a disease that was dangerous for the elderly, but was dangerous for them as well. Yeah. And I think the problem was that, on the myocarditis thing, people were sort of jumped on it so quickly that there was a huge amount of publicity and interest and decisions made, and in this instance, guidelines published before actually a bit more evidence emerged, and it turned out that hang on, maybe this isn't quite such a big thing.
Yes.
Or maybe this isn't really much of a thing at all.
Yes.
Which, and this goes back to basic principles, I guess, of clinical evidence, which is that, there's rarely ever is one paper a kingmaker. We don't suddenly change all of science it doesn't spin on one paper. You wait for a body of evidence that's consistent, because we know that medicine is complex and we're easily duped, and we find patterns where sometimes there aren't any. And I guess maybe this was a bit of an example, but and now we've got a great guideline for children to show for it.
Yeah. Well, except my papers, which are practice changing, all of them. But
exactly. Yes, mine too.
Yeah. But we have this great guideline, which is, I don't know. I just, last point that I'm going to move to the next topic. I just want to say that, I just really baffled that, do people ever think through the practical consequences of a recommendation that, so many children are going to have to see a pediatric cardiologist? And what is a pediatric cardiologist going to do? You want them to do echoes on all these kids or EKGs? Those are interventions that are unproven. So I don't know what that's going to lead. They'll find a lot of nonsense. In fact, we're moving away from that in other settings. It's just madness. I
mean, if you look at the data now as well, I mean, in the US, I think you've had 1 million children with confirmed infections or something. So is that 1 million pediatric cardiology?
No, they had to have fever for 3 days. So maybe that's only 200,000. No, I don't know. Maybe that's 100,000.
Oh, thank goodness.
Thank goodness.
Only
100,000.
200,000.
And I don't think people know. Pediatric cardiologists, they don't grow on trees. There's so few of them. There's so few of them. They have a hell of a time getting a job, from what I understand, these pediatric subspecialties. I don't know. In this country, unfortunately, so many of them they make less money than a general pediatrician, and it's very difficult to get a job. So it makes me question.
They've got a lot of other stuff to do, pediatric cardiologists, because believe it or not, some of their patients are pretty poorly.
Yes, I know, and that's the other thing. Yeah,
having pretty major surgeries on day one of life, on ECMO for a while. It's they've got some pretty important stuff to do.
And the next one, and then the next clinic visit would be the person with massive VSD and all these sort of complications, and then the next patient on the list would be Tommy, the 6-year-old who had COVID, who's been wanting to play for 5 months, and his parents have tied him. I don't know how they would suppress him from raising his heart rate to 80%, but somehow they've kept him in this cocoon, waiting for the appointment, and little Tommy just wants clearance, and when he finds out that it's just going to be a few questions, and if he answers correctly, he's going to get to play, I don't think he's going to be too happy with this whole little setup. Anyway, okay, next question. long COVID. It's a very interesting topic to me because obviously it is obviously people are suffering. That's for sure. I mean, people who have symptoms and they come to the doctor are suffering, and they deserve the very best empathy, supportive care. The second part, I think, is that after any prolonged, protracted illness, recovery is not quick. I mean, we've all seen people, weeks after pneumonia. Even as I've gotten older, I'm not that old, but, I get hit with a really bad cold or flu, and I think I've had them before. Who knows? But, it takes me a long time. I was once telling somebody that I swear to God, I had a sore throat for like 8 weeks after a cold. No, of course, people didn't take me seriously, but I was lozenging up.
It's the man flu, Vinay.
It's the man flu. Yeah, that's what I told people. I was a beast of a man flu. Everyone else I knew was doing quite well. But we know that there's prolonged recovery for many illnesses. With COVID, I think surely that will be true. There will be people with long-term sequelae of COVID. At the same time, not everything that happens after COVID is due to COVID. And I think it's really a challenge. It's a scientific challenge to attribute what's to COVID, what's not to COVID, and what can you do about it. Just like when the vaccine is deployed, there are going to be things that happen to people after getting a vaccine that may not be due to the vaccine. I saw a recent report that said some people may have Parkinson's after COVID, but of course, the rate of Parkinson's was so low, it was unlikely to be due to COVID. I didn't know that COVID would go into the portion of the brain and remove the dopamine or whatever it is doing. I'm not aware of that. So I guess my question is, how do you think about long COVID? We don't want to sensationalize it. We also don't want to downplay it. How do you walk that middle path on long COVID?
Well, long COVID, I find it difficult to talk about as one single entity because it's probably, as you said, it's several different things. So I personally, I find the name unhelpful because I think it sort of distracts from trying to work out what's best for each of these different groups of people. So, like you say, we know that after pneumonia, it can take people 6 months to a year after a bad bacterial pneumonia to get back to normal, and it's quite routine for them to feel really breathless and exhausted for time after that. So we'd expect the same after a bad viral pneumonia. For patients who are in intensive care, we know that there's a whole host of respiratory and mental health problems that can be associated with that. We know that following a lot of viral infections, that people can get a sort of chronic fatigue type illness. And then there's also there seems to be sort of a small portion of people who get COVID who afterwards have a sort of autoimmune reaction where they get persistent fevers and some other GI symptoms. And then there's people I work with some colleagues who just still can't smell at all or taste, and that's the only symptom they still have. But that's long COVID by by the sort of definition. And the problem is these groups of people don't all need the same stuff. In fact, the support they need is all quite different, and the research questions you want for each of them are quite different. So, the doctor you want to see, the investigations you want to have, the treatments, the research that needs to be done is sort of specific depending on what you're talking about when you say long COVID. And I think a lot of the public find it a bit confusing as well. They think it's chronic COVID infection. So, that you're still infectious if you have it and this kind of thing. So I think personally, I personally prefer it being delineated by what the specific ailments or conditions are, and I think that's starting to happen a bit more now in the UK. The NIHR sort of did a scoping exercise recently that have broken it down into those groups actually more or less, which is helpful. And then I think as you say, trying to delineate some of the more vague symptoms that could be, due to things other than COVID. I mean, we're just never going to know. We know that even if you test people now for serology, if they were infected back in March, there's a reasonable possibility people would be seronegative. So there's really no way of confirming it. But at the end of the day, actually, for most of these things, whether it was due to COVID or not, is not that relevant by this time, because what the treatment that you need is really supportive. It's it's based on the symptoms. It's about trying to help people regain function, and that sort of stuff. For some things, it might be there. I think there's some evidence that there might be sort of persistent virus in olfactory bulbs and that sort of stuff, if those are the kind of the things that you're getting. But for a lot of it, it's not. So I guess what it helps to delineate by what exactly the symptoms are. It helps to just focus on the symptoms and how to try and help people improve quality of life and regain function. And I think delineate research questions by the particular, syndrome, whichever sort of post-COVID type syndrome it is, and what the cause of that is. But yeah, you raise an interesting point about vaccines as well, which I think is something we're going to have to think about in the surveillance era afterwards.
It's called long COVID vaccine.
Long COVID vaccine.
Long COVID. We talked about those 2 Twitter polls. One Twitter poll, they love long COVID. Everything long COVID plays because it makes COVID's worse. It's worse than you think. And even if you don't have it bad, you could have it bad. So that's good for them. But then the other side, they're waiting for long COVID vaccine. Long COVID vaccine is the vaccine, everything related to the vaccine. I got a vaccine, then I got a car accident, and that was obviously due to the vaccine.
It was the next day. The very next day.
Because obviously I couldn't see that car coming at me. Right. But anyway, we shall see. I think I guess what I would think is the right path is, of course, attribution should be carefully done, and to some degree, it doesn't matter where symptoms come from; they need to be treated. And I wrote something where I think if a lot of people come in with anosmia and somebody gets the bright idea that let's try venlafaxine, let's just RCT that venlafaxine for anosmia. I mean, I don't know. I'm just making things up because that's what people will be doing. Actually, quite soon. A lot of doctors are going to be making things up, like, oh, let's try gabapentin. And the reason gabapentin didn't work is, of course, we didn't give you enough capsules. We got to keep increasing it until it works.
Well, you make a good point, because that is going to happen, and that isn't what should happen. Because what should happen is, of course, there should be clinical trials. Yeah. And I know that I'm sure it's probably the same in the US, and here we're having sort of long COVID clinics set up, so dedicated sort of clinics. And I mean, especially if you're going to centralize a service, do a trial.
Yeah, do a trial. It's so easy.
You need to do a trial.
Just do a trial.
Exactly.
Just randomly assign people. And I will say one thing, though, about the long COVID services. I don't know if you've gotten the memo, but hospital revenue is a bit low. It's a bit low in this country. And we're not like NHS. We got to make that up. And so we have going to long COVID cardiac MR these people until it resolves, obviously, because you don't want to just stop the MRs. You want to keep them going until it looks like a normal heart.
You need at least 2 normal scans.
At least 2 normal. That's right. That's what I always tell the trainees. At least 2 normal. While I'm looking at the bank sheets, I tell them at least maybe 3 normal if we're still in the red. But if we're in the black, we'll leave with 2 normal. But I think there's a worry. I mean, obviously, the pressures on these hospitals to get their business back together is going to be strong. And there's only so much arthroscopic surgery we can do. There's only so much we can do on arthroscopic knee surgeries.
Just put some more stents in.
There's got to be some stable disease somewhere. So, okay, then the last thing I wanted to talk to you about, then I have to run. Schools. Since we last talked, which I thought was, obviously, I had assumed it was going to be the most meaningful conversation in the United States and change everyone's mind. I don't know, it may have fallen a bit short.
Did it not happen?
Yeah, I don't know. I don't think it happened as I intended. But I think you'll be pleased to know that schools in many places are still closed, and in other places they are actively trying to reopen. You'll also be pleased to know that we don't let anything like local test positivity or rates of COVID affect those choices. Those choices are completely independent of any of those data. So that's the good news, that they are made completely capriciously on a whim and based on the lobbying power of the local teachers unions, which is probably the worst thing imaginable. And although many social activists turn to Twitter for hashtag empowerment slogans, when it comes to this discriminatory action, probably the greatest discriminatory action in the last quarter century in this country, because it will affect Hispanic and Black children much more, and poor children much more than any other children, people are notoriously reticent. So it's good to see that the advocates are keeping quiet where it really, really matters. I don't know. I saw you had a new review out. I read it. Of course, it is actually quite fair and quite balanced, I thought. You know, it was a terrific review of what we know and what we don't know about kids and viral transmission and risk to them. And you acknowledge Kawasaki, although you didn't dwell on it, thank goodness. So I guess I'm thinking, you know, what's going on in the UK about schools? When you look over at this country, do you guys like laugh? I mean, what do you, do you like cry? I mean, how do you even look at us? Do we just, is it just an,
I don't know. I mean, it's always difficult to talk about. Yeah, it's hard to say, you know, what you think about the US because, you know, you're like 100 different countries really rolled into one because, you know, each state is doing its own thing, which, you know, it seems often is sort of based on whether it's blue or red. But I mean, I can say for the UK, so we're obviously in the middle of our second surge at the moment. You guys have raced ahead and gone for 3 surges, which is quite impressive. But we're just on number 2, and we've kept schools open. So cases started rising really towards the end of August, and took off quite explosively in September among young adults, which is what's happened elsewhere. And schools have stayed open here, and that's been the case in a lot of Western Europe actually. So France and Spain both started their second surges before we did, and kept all of their schools open. Germany's schools are currently open. Italy's schools have been open. I think they're talking about possibly closing secondary schools or the older years in secondary education.
But because you were open, you were unable to control the spread of the virus.
Well, it's interesting you should say that, Vinay, because what we found is similar to what's happened in many other countries before, including, and cover your ears, anyone, Sweden.
Oh, sure.
During the first wave.
We'll put a censor warning on this, trigger warning, Sweden. Yeah.
But I said before that whatever you think about Sweden's response, whether it was, you know, pure evil or pure brilliance or something in between, what we did learn is that you can suppress transmission with schools fully operational because they continued in-person education for children 16 and under throughout. And, you know, it was very useful that they did that because it wasn't, you know, a blind experiment this time for Europe doing the same thing. We realized, you know, we've seen that it's happened before. And so there was a few countries before England who managed this. So Iceland had a really big second wave and kept schools open. Ireland as well managed to keep schools open and suppress transmission. France was a few weeks ahead of us and brought their cases crashing down with schools fully open. And England has just turned the corner in the last few weeks. We had a more almost complete national lockdown. And so, you know, you were not allowed to meet anyone from another household indoors. You know, all non-essential retail was closed. So that was anything basically apart from, you know, grocery stores.
What about playgrounds though? Did you strike where the virus is the worst?
Though we somehow managed to keep that viral reservoir open.
You did? You kept the playgrounds open?
You kept the playgrounds open.
So you're saying you banned dinner parties before you banned playgrounds?
And casinos. It's wild, I know. But yeah, we decided to close those things before we took away children's right to play and for education. But yeah,
well, you know, hey, Alasdair, you should know that closing the playground's no big deal because they haven't seen the pediatric cardiologist anyway, so they can't go.
That's right. They can't go back anyway. They can't get a clinic appointment until next April. Yeah. But yeah, I mean, and look, it's been tough. I think there was a lot of pressure from teachers' unions and teachers, and understandably, I think a lot of teachers felt quite scared because everyone else is sort of working from home, and they joined the ranks of essential workers. The acknowledgement that education was an essential service, an essential activity, and so bus drivers and people in grocery stores and stuff, teachers were going to work even when cases were shooting through the roof. And all credit to them. They've had an extremely difficult job because it doesn't matter, even if you have zero transmission happen in schools at all. If 1 or 2 in every 100 people in the country are infected, you're going to get a lot of cases in a school with 1,000 people in it. Whatever happens, and the schools are having to manage that. They're having to do their own sort of contact tracing elements and phone health protection agencies and sort all that stuff out. So they've taken on a huge burden of work, but it's meant that the vast majority of kids have managed to stay stay in school. And now cases are on the way down. We'll see what happens as things start to gradually reopen. But what's really useful is the UK has a method of testing that is not based on symptoms. So we've got 2 surveys, right, that run with large scale random population sampling. So one of the big issues that people always complain about with the case numbers in kids is that we don't test enough kids because they don't get enough symptoms.
Right.
Which is true, to an extent. Sure. That's true. And it's never been clear to what extent we were under testing. But obviously we don't get that with these surveys. And what we found was that very reassuringly, you can look at it 2 ways, but when there was an explosion in cases, it was in young adults.
Yes.
So it was in people sort of aged 17 to 25.
Who are still probably meeting up on dates and things like that, whether anyone wants to believe it or not, that's happening.
Exactly, yeah. So that's where cases exploded. Now, behind that, the second highest rates were actually in secondary school aged children. Mm-hmm. So these are children sort of aged 12 to 16. And to some extent, that was expected because when we've seen from the literature that when cases get really high in the community, you do get outbreaks in schools, primarily amongst older adolescents. Yes. And you've got to remember that at the time, basically, half the country, because we have regional lockdowns, half the country basically wasn't allowed to socialize at all. And the other half of the country, people were still having to work from home and you can't meet up more than 6 people. So essentially the only people whose life was almost normal were school children because they were still going to school and having in-person education. So you're getting a lot more mixing in those age groups. So interestingly, they followed behind. Now, what was particularly fascinating was that then after cases started rising in almost all other age groups, eventually they also started rising in primary school age children aged 2 to 11. Mm-hmm. And they eventually came up and reached a similar sort of plateau to where other adults' rates have been. But this is what's been seen elsewhere is the young adults set the trend behind which the children follow. And this is the opposite of what we would normally expect for, respiratory viruses. And it's been particularly fascinating to see that the youngest children who are the group that everyone has been most concerned about because they are, the snotty coughing, disease vectors that everyone worries about, were the group that, the cases started increasing behind everyone else and never exceeded the rates that we had in adults. In fact, was lower than most other adult groups. So it's been really interesting. And to see then as the cases dropped in adults, then, about a week later, they then started falling in children as well. So that's been a really interesting pattern to observe in real time with data that's unbiased by the sampling method because it's random testing.
That's well put. Alasdair Munro, thank you so much for your time. I appreciate all these discussions, and listeners should follow you on Twitter for some sense. Perhaps listeners should try to correct the incredible polarization by liking and retweeting things that strike the appropriate balance. And I'll be looking on your side of the pond when what we have done in the U.S. really manifests itself in the next 10 and 20 years, and we take a generation of kids, deprive them of school, further inequality, and the civil unrest that will ensue. I hope you have some jobs open for me then, because I'm gonna have to get out of Dodge when it gets really hot. Because I do worry. I think it's going to be the most destabilizing event in the country that was already on the brink.
And it's still ongoing as well.
Still ongoing.
We'll see what happens. You've got a new administration coming.
Yeah.
Winter can't last forever. Vaccines are on the way. Let's hope. Let's hope.
Alasdair Munro, thanks so much.
Thank you.
You've been listening to Season 3 of Plenary Session. Plenary Session is produced by Kiana Klossner. Music by Ian Straley and Audrey Tran. The views expressed on Plenary Session are those of whoever said it and no one else. Plenary Session is not medical advice. Follow us on Twitter at plenary_session. Until next time.